Good morning, everyone. My name is Monica, and as a clinical program manager at InBody USA, I want to welcome all of you to our second annual Oncology Symposium. During the symposium, we will have speakers from different institutions who will share their research and clinical expertise in exercise as medicine, lymphedema, and sarcopenia in cancer patients. As shown in your screen, first, we will have 2 sets of 2 talks each, followed by 10-minute breaks. And we will close our symposium with a talk from Cleveland Clinic, followed by a panel discussion and Q&A. During the talks, as well as after, attendees will have a chance to ask questions by adding them to the Q&A box on your screen. If you want to address your question to a specific speaker, please note that in your submission. Our first 2 morning talks will be by Dr. Christina Dielli-Conright and Dr. Colin Chan. Dr. Christina Dielli-Conright will talk to us about body composition in oncology and its applications from exercise science. She is an associate professor of medicine at the Harvard Medical School and in the Division of Population Sciences of the Department of Medical Oncology at the Dana-Farber Cancer Institute. Her research is focused on examining mechanisms by which post-diagnosis exercise can impact cancer prognosis, with a specific focus on biomarkers related to tumor growth, inflammation, metabolic dysregulation, and body composition. Her work involves adolescents, young adults, and adults, as well as looking into cardiometabolic disease in minority cancer survivors. Before 2020, she was the director of the Integrative Center for Oncology Research in Exercise and an assistant professor of biokinesiology and medicine at the University of Southern California. She completed a postdoctoral fellowship at the City of Hope National Medical Center after earning her PhD from USC. Without further ado, I'd like to welcome our first speaker, Dr. Dielli-Conright, to join us. Thank you.
Thank you so much. Thank you for the kind introduction. I really appreciate the opportunity to be here and to speak. And I'm just going to pull up my slides and share screen here and go ahead and jump in, especially for the interest of time. I'm thrilled to be here and talk about body composition oncology, in particularly how myself as an exercise scientist and clinical exercise physiologist utilizes it in my everyday research laboratory. So again, thank you for the opportunity to speak here. I'm just going to go ahead and jump right in. There's a number of plethora, if you will, of investigations with the importance of body composition as it pertains to the cancer continuum. Associations between body composition and cancer-related outcomes include patient-reported quality of life, dose-limiting toxicities, post-operative complications, hospitalizations, and then important outcomes on mortality, such as disease recurrence, disease progression, cancer-related death, and overall mortality. This is emphasized in the figure that you see on the right here that's in essence focusing on body mass index across the cancer continuum, noting that high body mass index increases the risk of developing multiple types of cancer, as shown on the left-hand side there in the red with cancer incidence. If you look on the bottom right, high body mass index decreases the risk of poor outcomes in multiple types of cancer or mortality. So it is not known where along this continuum the prognostic effects of high body mass index begin to reverse, may begin around the time of diagnosis or before, but nonetheless, these are some of the early synthesis of investigations focusing on BMI, as we know that that's commonly measured in clinic. Why body composition? Why do we need to delve a little bit deeper in why are there so many imaging modalities that we need to consider? And I'll discuss some of these towards the end of the talk too, as far as where can we go from here. But you know, the types of figures like this, especially with detailed imaging, really emphasize the point that 2 individuals are not the same when it comes to body composition, even if their waist circumference is similar. These are abdominal scans, as you can tell, where the individual on the right may have more subcutaneous adiposity. The individual on the left may have more superficial adiposity, even if muscle volumes are slightly similar or whatnot. So it's really important here to have imaging techniques and body composition modalities to allow us to look at intermuscular adipose tissue, visceral adipose tissue, subcutaneous adipose tissue, of course, as we know, muscle, and these become important, as I mentioned on the previous slides, with various outcomes. Specifically to muscle, just using this tissue compartment as an important example throughout the cancer continuum, we know that muscle begins to waste over time. This is an age-related phenomenon, and it's further exacerbated throughout the cancer continuum process. So if you look in the solid blue line there, age-related decline in muscle mass is approximately 1 kilo per year. However, for individuals diagnosed with cancer, that cancer-related decline in muscle mass occurs much earlier and potentially much more rapidly. So really, we have an opportunity here to use body composition assessments to track and follow muscle mass changes, as well as adipose tissue and other tissue compartments, in order to determine how we can best intervene and when. So assessing body composition in clinical practice right now with oncology is really limited to body mass index. I would say, in my opinion, that is the standard of care. Clinically, when a patient comes in for treatment or to see their medical oncologist, their height and their weight is assessed routinely. Therefore, there's a plethora of data, as I mentioned earlier, around BMI and the utilization of BMI as it pertains to cancer outcomes. However, we know there's other traditional strategies, as seen on the left-hand side in this table: body circumference, such as waist and hip circumference, skin fold thickness, and bioelectrical impedance, as we're aware of from our sponsors here with InBody. Advanced imaging strategies on the right-hand side include DEXA, dual energy X-ray absorptometry, CT, MRI, and PET scans. And I'll talk about most of these on the next subsequent slides, not necessarily focusing on the technology and the physical properties of the imaging strategies, more just on sort of the pros and cons, both clinically and from a research standpoint, of how these can be utilized. But I think the bottom line is this: that measures of body composition need to be responsive to change. They need to be feasible and potentially cost-friendly, interpretable, and associated with a clinical outcome to be meaningful within oncology and exercise oncology. So jumping into some of these modalities, we're obviously all familiar on the call with InBody, BIA, with InBody being one of the manufacturers of BIA. This form of body composition modality is excellent in that it's relatively affordable. I say relative because this, of course, would depend on an institution or a researcher or clinician to have the resources to be able to support purchasing such device. Fast as far as producing results, portable, user-friendly, and there's no radiation exposure. This is a great way to be able to obtain detailed information about body composition at a low cost in a relatively short period of time. Moving on to DEXA. DEXA is commonly used, as we all know, for bone mineral density. That is what its usage is approved for. However, as the audience likely knows, when you run a whole body scan on an individual, as shown in this image here, you can then capture fat-free mass, fat mass. You can, of course, capture body weight, et cetera. And so there are body composition features that you can obtain from DEXA. This type of modality is going to be more accessible than CT, PET, MRI. However, individuals that likely have had a DEXA scan have been prescribed to do so by their physician to usually assess bone mineral density. So it's used in clinical care in that fashion. As an investigator, I often use DEXA because I'm fortunate enough to have access to such a device for the sake of research purposes. So generally, this is one modality that we use quite heavily in my lab, which I'll talk about shortly. D3 creatine dilution is another method. This is known to be a direct assessment. An individual ingests D3 creatine that leads to creatinine production in the muscle. Then under a second fasting morning urine, about 2 to 7 days later, D3 creatinine enrichment is measured. And so there is a biologic specimen that is involved here, and that the urine needs to be captured. There needs to be access to the D3 creatine. Again, this is known as a direct measure, does not require dietary control, and the subject burden can be relatively low. But again, this is not in clinical practice for oncology, and this would be something that is primarily used by researchers if they have the resources in order to employ this type of modality. Moving on here, just lastly to CT for the interest of time, because obviously we can also talk about PET and MRI, but this is readily available for image analysis. This is used in clinical care for certain cancers, particularly advanced stage cancers, or potentially even heme malignancies. Serial imaging is usually available because patients will have images taken repeatedly. Again, this is not heavily used in research without having some type of support for funding, because doing CT scans strictly for research are quite expensive. I can talk personally about what we do with CT scans that are collected as standard of care. Is we have a biorepository at Harvard where we can access that data and we can look at body composition related questions post hoc. And have access to not just the clinical data, but also the CT scans, any type of patient diagnostic treatment related data as well. So fortunately, we are able to tap into that, and it's a great resource. I know other institutions also have a similar approach with CT scans where these can be banked. The common location of assessment for body composition is the L3 middle slice, which is shown at the bottom of this particular figure here. So I'd like to use the remaining time that I have just to mention how we've utilized body composition in our laboratory. And we definitely find the high value in being able to assess body composition. We really look to sports and exercise science to take an exercise as medicine approach in my laboratory, both with prescription of exercise and then how we're conducting our research. And the reason I lean on the sports and exercise science realm is that approach to training, to performance, et cetera, in programming of exercise is actually no different than what we're taking with cancer patients. So it's goal focused. It involves performance testing. This is where we would include body composition testing, periodization and progression of exercise, and oversight by qualified trainers. So when we're thinking about how we're intervening with patients diagnosed, we use those same principles and think about rigorously how we can apply exercise and associated measurements such as body composition to those diagnosed with cancer. We know that exercise oncology trials draw upon evidence from exercise science to determine modality, and this speaks largely to body composition. Years ago, the emphasis was around obesity and the detriment of obesity with cancer risk, cancer mortality, and that evidence still holds true. However, many of you have probably noticed in recent years, there's been more attention given to skeletal muscle mass and the importance of maintaining skeletal mass, preserving it, with from the standpoint of exercise and nutritional support. We know, as you can see on the figure on the right-hand side there, that exercise and nutrition interventions collaboratively mitigate body composition changes in individuals with cancer. And therefore, we can use these strategies in essence to offset all of the negative treatment side effects and just general effects from being diagnosed with cancer, changes in lifestyle habits, et cetera, with exercise and nutrition. And this is not only true of early stage cancer survivors, but this is also true of metastatic advanced stage cancer survivors, whereby studies have successfully demonstrated increases in fat mass, decreases in, increased fat mass, potentially decreased fat mass as well, and decreases in lean mass over time as a result of all of the treatments and side effects of cancer itself. So prime opportunity here to use body composition, as we know, especially existing resources in the example of CT, if that is at one's disposal. So I'm going to jump into a handful of slides here just to show an admixture of what our laboratory utilizes with body composition and how we've been integrating it with interventions per se. So one example is in a study we did years ago now that found that aerobic and resistance exercise improved sarcopenic obesity in sedentary, overweight, or obese breast cancer survivors. This was funded by a KO7 award that I had at the time, published in JCO, where the primary outcome was actually metabolic syndrome. Here I'm showing you the body composition data. We had patients undergo a whole body DEXA scan before and after the intervention. And you can see based on the left-hand side there with appendicular skeletal muscle mass index, that skeletal muscle mass improved by 32%. And on the right-hand side, the BMI decreased by approximately 16%. The solid line is the exercise group. We were really pleased with this study that the individuals lost weight in the absence of a dietary intervention. This was likely due to them being novice exercisers who were over 95% adherent to exercise that really induced that caloric deficit needed to lose weight, but it was not designed for weight loss. So again, we use DEXA in this particular case for accessibility and affordability. We had access to a DEXA in our research lab, have access to a DEXA in our research lab at no cost, thanks to support that we have from our institution. And therefore, we were able to integrate DEXA into this particular study in breast cancer. An additional example, which was led by a doctoral student of mine, Jackie Dawson, who's now at Long Beach State in California, is a finding that supported that periodized resistance exercise improves lean mass in prostate cancer survivors. This was actually the primary outcome of our study at the time. We wanted to use periodized resistance exercise specifically to target lean mass, given that men who are receiving androgen deprivation therapy for prostate cancer often see a dramatic decline in lean mass, unfortunately due to that castration effect on testosterone. So you can see on the far left-hand side here that at baseline in the exercise group, about 38% reported having, or was assessed, as having sarcopenia. And then by the end of the intervention, after just 12 weeks, that number was reduced to 15%. The middle figure there, you can see the significant improvement in sarcopenic index, as well as the lean mass change reported as kilograms. Again, we use DEXA for similar reasons. We have access to it in our laboratory, was not an additional cost, and we were able to get different facets of body composition from this particular measurement. I'm going to wrap up with just a handful of trials that are ongoing. So we don't have data on these particular trials yet, to just show again other utilizations of body composition modalities. Our Clarity trial is evaluating the effects of 16-week HIT intervention on cognitive function in breast cancer patients receiving chemotherapy. This is an ongoing trial that's about to wrap up, and we chose to use bioelectrical impedance in this particular setting for the sake that our primary endpoint was not body composition, it was cognitive function. And therefore, we wanted to choose a very cost-effective and time-effective method of body composition so we could have that data, but that it didn't add additional burden or cost to us if needed. So we're using BIA in this particular study. In an additional trial that's focused on pancreas cancer, we're using a virtually supervised resistance exercise intervention with protein supplementation to look at skeletal muscle mass changes in adults with pancreas cancer receiving chemotherapy. And here we're really capitalizing or leveraging the CT scans that are standard of care. So we will be analyzing body composition using CT. Again, they're accessible to us and there is not a cost associated for us to access those scans, and therefore it makes sense to utilize that modality there. And then lastly, we have our POWER trial, which is evaluating the effects of exercise on cardiovascular risk factors among Black men with prostate cancer receiving ADT. Here we're choosing to use DEXA scan, again, giving us additional data related to body composition. And we have the cost and the time in order to integrate this modality. And we feel that it is important given that Black men are largely understudied with exercise oncology trials, and we want to have this data accessible to us. CTs are not done as standard of care in this particular population. So I think the big question is, how do we standardize body composition for both clinical and research practice, or do we? I think a few takeaways. Multiple modalities exist with varying pros and cons, as we all know. There are currently no standardized thresholds for classification of abnormal muscle mass or adiposity for cancer survivors. Therefore, are those sarcopenic cut points relevant in cancer? We have yet to really establish that, although I know there are a lot of organizations that have recommendations for that. One modality may not be able to provide all of the information needed for specific body composition measures, so that could be challenging. And relative ease of use and immediate clinical impact is of utmost importance. We want to get the most bang for our buck in order to be able to integrate a certain type of body composition modality across practice, both clinically and research. And we have yet to really agree on what that particular modality might be. So just to finish up, I'd like to thank my collaborators in my lab, the funding support that allow us to study body composition throughout all of our research studies, and of course, the participants for all of their time and dedication to our studies. Thank you so much.
Thank you so much, Dr. Adele Conrad, for sharing that interesting studies. I know you work with us. Next, we're going to have our next speaker for today, Dr. Colin Champ. Dr. Champ is a board-certified radiation oncologist and an associate professor in the Department of Radiation Oncology at Drexel University College of Medicine. He was previously an associate professor at Duke University Medical Center prior to designing, building, and leading the Allegheny Health Network Cancer Institute Exercise Oncology and Resilience Center. He specializes in the treatment of patients with breast cancer and lymphoma. His research focuses on both cancer treatment with radiation therapy and the interaction of nutrition and exercise in cancer prevention and treatment. Dr. Champ received a bachelor's degree in chemical engineering from MIT and his MD and specialty training from Jefferson Medical College at Thomas Jefferson University. He has published over 70 peer-reviewed studies, wrote 3 books on nutrition and exercise, and has contributed to multiple textbooks. Now, I'd like to welcome our guest speaker, Dr. Colin Champ, to join us.
Thanks so much for having me. It's great to be here, and what a great talk. The last talk was really, really good, so thanks for that. Today, we're going to talk about how we're viewing the gym in the sense of how we can beat cancer both in the clinic and the gym. Again, I'm an MD, I'm a radiation oncologist in CSCS as well. We have 2 centers, one in Pittsburgh, it's the HN Cancer Institute Exercise Oncology and Resiliency Center. Then we have a community-based center in Naples, Florida, which has about 350 plus cancer patients go through it per year at their training program. So a lot of these slides that I'm going to be talking about are not new to this audience for sure. When I present to the MDs, oftentimes they are new, but we know that activity levels, and from now on, in the sense of the populations that I'll be discussing, it'll be breast cancer patients, and a lot of this holds for really the whole cancer setting. But this is where most of my research lies. So this is where most of these slides will be pertaining to, and we know that women that are more active after treatment for breast cancer do significantly better with this treatment. This was shown to us in a study last year, looking at over 1,300 women treated for breast cancer. And what this group found was that at year 1, those women that were quite active had a almost 43% reduction in risk of their breast cancer recurring and a over 50% reduction in the risk of dying. That increased at 2 years from a 55% reduction risk of their breast cancer recurring. So again, breast cancer specific outcomes here affected potentially by activity levels. They had an almost 70% risk reduction in dying. Obviously, if that was a drug, we could charge millions upon millions of dollars for it, and insurance would likely pay for it. When we look at change in mortality with activity levels, they did find that those women that were most active, high activity levels, had an almost 70% drop in their risk of mortality. So this has raised a lot of physicians' eyebrows in terms of how exercise and activity levels can synergize with current cancer treatments, especially in the breast cancer setting. And this is data that was shown in the last presentation. Digging a little deeper, it's not just exercise that's associated with better outcomes, it's also body composition. And in body composition, we think of muscle mass, which this study looking at 3,200 women back in 2018 published in JAMA, what they found was using CT scans for body composition, those women that were not sarcopenic, i.e. had normal or high muscle mass, had a significant increased risk of survival after their treatment for breast cancer. When they looked at adipose tissue, it was the exact opposite. Why does this happen? Well, I view adipose tissue and muscle mass as really organs with opposite effects. Both are obviously vital, but there's something about contracting muscle mass that secretes multiple normal hormones that fuel our normal anatomy and fuel our immune system. And from a cancer point of view, that may be most important on this slide. You see that muscle mass secreting many important hormones, but that IL-6 that goes and regulates our neutrophils, lymphocytes, and macrophages, i.e. it helps stimulate our immune response, which can help us fight cancer cells. Whereas adipose tissue on the right does the exact opposite, increases inflammation, causes immune dysfunction, causes harmful elements like tumor necrosis factor, interleukins, and VEGF to be produced. So the picture this starts to paint is, it's not just BMI as we just discussed. It's not just activity levels. There's something about having more muscle and less fat that can help improve outcomes. And we could have a whole 15-hour-long discussion on adipose tissue and ways to affect that through dietary changes. But obviously muscle mass, from an exercise point of view, that is the #1 way to increase this. So one of our students looked at some of the papers that have existed in breast cancer populations. And there's plenty of papers doing similar analyses, but when we used Schoenfeld's threshold for hypertrophy, that's 5 sets per muscle per week, or 10 sets per muscle per week, looking at all the movement-based activities and exercises that exist. So compartmentalizing to push-pull, hip hinge, squat, and core, and seeing how many of those muscle groups reach those thresholds. You see there's a deficit here when it comes to breast cancer populations. And a lot of this is totally understandable. Many of these studies are quite old. Many of them happened initially, they were trailblazers for us now. But as you can see here, many did not even, about a third did not even describe what regimen they were doing. And in terms of those that reached the minimal hypertrophy volume, there's a few, and there's only one that reached the optimal hypertrophy volume. So a lot of our work has been to look at why isn't this happening, and how can we push our cancer patients so that we can see these hypertrophy thresholds. And part of this is what is the dose that we're prescribing? So I treat women with breast cancer with radiation therapy. I don't just use radiation, right? We have specific doses, we have specific techniques, we have specific areas where we point our radiation. And from an exercise oncology field, we need to start doing the same, especially if we want insurances to pay for this, and especially if we want to see the outcomes, not just in research studies, but throughout the community. So when you look at studies following the ACSM guidelines, 30% of them don't comment on the regimen, 50% of the recommendations are identical. If you ask some of these researchers or even some physicians, they would say there's something unique about breast cancer patients that mitigates the benefits of exercise. And we would argue that's not the case at all. We would argue that it's the methods that are the issue, right? We're not contracting the muscle cells to the threshold that we need to. We're not causing hypertrophy that we need. So we're calling for targeted and dose escalated resistance training. And we want this to mimic the sports performance world, just like was discussed in the last lecture. And these are based on some of the basics that we all know hold in non-cancer populations. And what we're all trying to prove is that they will hold in cancer populations, which I think we all know as well. We know that strength correlates with muscle fiber. We know that set amount, or how much you load the muscle, correlates with bicep thickness, quadricep thickness. We know that as these sets go up, the chance of causing hypertrophy goes up. Certainly in newcomers, and obviously in trained individuals, it gets a little more difficult than that. But a lot of the studies, if you look through, we're not providing the dose of exercise that's necessary to increase hypertrophy. A lot of this is because we need to do it in a safe setting where we can lay eyes on these individuals and ensure safety and efficacy. And one area that's a real elephant in the room, especially in the breast cancer world, especially in a group of often postmenopausal women at risk for fractures, getting Arimidex and other anti-estrogen agents, further increasing their risk for falls and fractures. What are we doing to prevent them? This is a study that came out in 2009, looking at a group of individuals treated for cancer. This was breast cancer, women with breast cancer, and other cancers were included as well. And if you look on the right here, this is the risk of falls for the general population. So it's about 5% per year as we age, which is a pretty astonishing number at baseline. And that goes up based on whether you're treated for breast cancer or whether you're treated for any cancer. If you look at the risk of hip fracture, vertebral fracture, or any fracture, they increase as well. So what are we doing to stop the falls, right? We're putting some bone modulating medications. We're including those, but what are we doing to stop the falls? And I would argue not much, right? What are we doing to increase the firing of those neurons? And again, this is looking at non-cancer population, and this is just textbook stuff here from the NSCA, using heavier loads in order to optimize neural recruitment, increasing the cross-sectional area of muscles, performing multi-muscle, multi-joint exercises that can be done with explosive actions to optimize fast twitch muscle recruitment. So these are the cores of our facility and our resistance training and exercise programs. Bone density is no difference, right? It is no different. It's proportional to strength. And we know whether this is premenopausal or postmenopausal women. That's the difference here in the white or black check boxes. When we look at bone mineral concentration of the forearm or bone mineral density of the femoral neck, we know that it's proportional to strength. And that makes sense, right? We need to load our bones to cause these microfractures. We need to have strain from several different areas. We need tension, compression, shear stress. We need to wake up those osteoblasts, have them migrate to the area of the quote trauma, and we need them to lay down more calcium. We also need individuals to take vitamin D, vitamin K, and have adequate dietary calcium to pull it into the bone. So the question we've been asking in our studies, are a lot of these studies for convenience or are they for efficacy? And so what we want to do is move past checking the box. I think there is in the oncology world, a lot of checking the box, right? Our program has an exercise, or our Cancer Institute has an exercise program. It's a lot of 1 pound dumbbells and individuals not stressing themselves in the way they should. Again, just like I wouldn't prescribe 1 gray of radiation therapy to all my breast cancer patients, we shouldn't also prescribe the limit in terms of exercise, right? We shouldn't, to increase quadricep muscle activation, we shouldn't have the woman here on the left in the purple tank top sitting doing, seated leg exercises. We should have someone doing goblet squats, like in the middle here. Now, obviously, orthopedic and mobility issues have to be addressed. Chemotherapy has to be addressed. Any deficits from surgery has to be addressed. But most people in our clinic do goblet squats or some derivation of. Some individuals, like the woman here I buy butter off of, may take things to the next level, but she's almost 70. So it tells us just what our patients are capable of doing. And so again, if you were to walk around classes in our facility or resistance training sessions, you would see us following similar guidelines as the right here. This is some of Kramer's work. We do high force, strength, power training. We do some compound movements to start. We get more isolated as the exercise program progresses throughout. And again, we're keeping the rep ranges to increase hypertrophy, power, strength. We want to keep people muscular. We want to keep them strong. And we certainly want to keep our breast cancer patients off the floor without fractures. So the key thing here is we have to measure what we're doing. This has to be objective, and we have to start prescribing exercise. And again, I know a lot of the people listening right now, this is obvious to you. It is not so obvious in the medical field, especially when I talk with other physicians, right? We prescribe chemo, we prescribe radiation therapy. It's very prescriptive, right? Very exact. And then we say, go exercise, go walk, just move. Any movement's better than none. So we're arguing that if we don't hit that threshold, we're not going to see the benefits that we need. So everything must be measured and individualized. And the biggest metrics are muscle mass, fat mass, strength, balance, mobility, risk of falls and injury, resting metabolic rate we think is important, or VO2 max 2, and quality of life, so surveys. So what we do is simple things like the FMS, and I know we could argue all day whether that's the best screen. Y balance screen, I think, is utterly vital in this population. We have an InBody 970 that you see in the bottom right there, a very easy and user-friendly way to get body mass metrics. DEXA, CT, we have CTs on almost all of our patients, and they're great, but we can't keep putting individuals through CT scans. Obviously, there's a radiation issue. DEXA scan the same, much less radiation, obviously a high cost. We also do an ultrasound with the InBody as well to provide two separate tests. So statistically, we can make sure we're moving in the right direction. We have a VO2 master for resting metabolic rate. We do hand grip strength, and then we do a whole slew of quality of life surveys to ensure we're seeing the benefits we need. And then, of course, we're calculating load throughout the entire workout, right? Exercise is medicine. That is the prescription of medicine. That is the dose. Load is the dose. And if we're not loading enough, we're not going to see the benefits. And this is really the future of exercise oncology. So we're thankful for all the studies out there showing that this is what we need to do. And we're lucky enough to have a facility that's been funded by Highmark, which is Blue Cross Blue Shield, our 3,000 square foot facility in Pittsburgh. And we're lucky enough to have a 4,000 square foot facility in Naples. And the plan is obviously to continue to publish our data and to help convince cancer centers and hospitals throughout the country that they should too have an exercise oncology center that follows the metrics and the motto of the sports performance world. So I want to thank everyone for listening, and I look forward to questions here in about an hour.
Thank you, Dr. Sham, for a very insightful talk. And now we have our first 10-minute break. Please join us at 9:45 a.m., as you can see in the schedule, to continue listening to today's talk. Thank you so much. Welcome back, everyone. Our next speaker is Mr. Luke Krinsky, who will be talking to us about the effects of exercise on sleep quality and circadian rhythm. Mr. Krinsky is a doctoral candidate in exercise physiology at the University of Northern Colorado and will be defending his dissertation in 2 days' time on December 9th, 2022. He is also a current medical student at the University of Minnesota Medical School. He received his bachelor's and master's degrees in exercise physiology from Minnesota State University. His doctoral research focuses on the physiological effects of exercise and the attenuation of common toxicities associated with cancer. After medical school, Mr. Krinsky plans to become a physician scientist in the field of oncology. I am glad to welcome our next guest speaker for today, Mr. Luke Krinsky, to join us.
Yeah, thank you for the intro. Let me go ahead and pull up my slides. Okay, there we go. So yeah, I'm at the University of Northern Colorado Cancer Rehabilitation Institute, and we have the opportunity to serve the Northern Colorado region by using exercise as a form of rehabilitation for cancer patients as they go through treatment. And in doing so, we are able to conduct a lot of research and just kind of help spread awareness, as we're doing here today, on the importance of using exercise as a standard practice for the treatment of patients with cancer. In one particular study, and the study that I want to talk about today, is the effects of exercise on sleep quality and peripheral circadian rhythm in cancer patients going through treatment. And this is a study that we have been able to work with InBody on, and I'm going to go ahead and just jump in. So why is it important to study this? Now, cancer, as we know, tends to come about with a series of side effects, and the number one side effect being reported by cancer patients is fatigue, and behind fatigue is poor quality of sleep. And sleep disruption is very prevalent in the cancer population, and these graphs here on the right are from a couple different studies kind of assessing, based on or comparison from the general population, how often do cancer patients experience this disrupted sleep, and it is nearly double in not just cancer overall, but between different cancer types as well. And to make matters even worse, once a treatment regimen that consists of chemo or radiation is started, that impairment in sleep quality actually becomes worse. And so,
Luke, sorry, we're not seeing your slides yet. You can please share. Thank you.
You're not seeing my slides. Let me go. How about now? Let me start over. You can see my screen?
Not yet. Okay, there we go. There you go. Perfect. Thank you.
Classic.
No worries.
All right, so yeah, let me, I'll just jump to kind of where we were at. I just had some figures summarizing, the impairment in sleep across different cancer types. And then now starting into what happens when cancer patients start treatment is this sleep becomes even further impaired. And this table on the top here is just a series of aspects of quality sleep. So wake after sleep onset, sleep efficiency, sleep apnea, and so on. And with a control population that's healthy versus before beginning treatment and then after starting either chemo or radiation, these symptoms of sleep disturbance start to get worse and worse. And the figure in the bottom here, figure A is chemotherapy and figure B is radiation therapy. And this is just in breast cancer patients, just showing that the impaired sleep tends to be worse overall in patients that are going through treatment. And that poor quality sleep does not subside after that treatment is complete. So with looking at if exercise has an effect on quality sleep, we wanted to try to add in some sort of mechanistic approach to the study as well. And we know circadian rhythm tends to regulate our sleep-wake cycle, and that is the role of circadian rhythm in our body. And there's a variety of genes that we call clock genes that oscillate. They go up and down throughout a 24-hour day. And those genes regulate our physiological processes of our sleep-wake cycle. And these tend to be very disrupted in cancer. And they play a role in inducing tumorigenesis and worsening the burden of the disease when these genes are not properly expressed. And so this figure in the top here is from an animal model as well as a cell culture model, where the authors knocked out B-mal and period genes. And these genes are a couple of our core circadian clock genes, and they found that tumor burden was worsened. And then the number of colonies grown in cell culture was increased with these genes knocked out. And then the bottom figure there just represents the analysis of circadian rhythm with patients with chronic myeloid leukemia. So those flat lines indicate a lack of circadian rhythm. So there's a few different time points that the gene expression is assessed, and no change in that line indicates no change in gene expression or a lack of circadian rhythm. Whereas the top line is from our healthy population, that we would expect to see these genes to fluctuate throughout the day. So what is the impact of exercise on sleep specifically? So we know this is it's very heavily studied in the general population. There's a variety of theories behind why exercise may improve quality of sleep in the general population, such as reduced anxiety and depression, enhanced thermoregulation to help us fall asleep, and enhanced autonomic nervous system function. But the reality is we don't have a lot of data for the cancer population, and the data that do exist are survey based. And so there's a huge lack of objective data for quality of sleep in the cancer population. And so what about exercise and circadian rhythm? We know that exercise is actually able to phase shift our circadian rhythm, or the peak expression of a variety of genes. So exercise alone, this top figure here, shows that in a variety of muscles, exercise was able to shift the time at which these circadian genes peaked. And at the bottom of that figure where it says SCN, that's our suprachiasmatic nucleus. That's what is called our master regulator of our circadian rhythm. It's in our brain, and it's a component that regulates our peripheral circadian rhythm. And exercise was able to restore or to phase shift circadian rhythm in our muscle, but it did not have an impact on the brain, showing that exercise is an independent contributor of circadian rhythm in our peripheral muscle. And to further justify that, this image in the bottom here is a study where They knocked out BMAL, and BMAL, again, is one of these core circadian clock genes in a mouse model, and showed that sleep was impaired. And when they restored BMAL expression in the brain, sleep did not improve, but when they restored it in the skeletal muscle, it improved. So there is a role that skeletal muscle plays in regulating our circadian rhythm. So we wanted to see if exercise can help improve circadian rhythm that we know is impaired with cancer patients. So how do we do this? We're still working on the study. This is just a variety of pilot data that we have, but we have two groups: an exercise-based rehabilitation group, so patients that are participants that are exercising, and they're going through a 12-week exercise protocol, 3 days per week for 60 minutes each session. And it's split with aerobic and resistance training each session, and it's between 30 and 45% of their heart rate reserve or their VO2. And we have a control population, and these are sedentary participants that are currently receiving treatment. And we did a baseline analysis of circadian rhythm, which I'll talk about, and then continuous sleep tracking for a 10-day baseline period. They also wore the sleep tracking devices because they measure activity. We wanted to verify that our control patients were not indeed exercising during that 12 weeks. And then we did an InBody assessment before and after, just with the exercise group, to assess if there was any role or if there's any correlation between body composition changes and sleep or circadian rhythm changes. So in order to do this, we used a Whoop sleep tracking device. The Whoop strap has been validated against polysomnography to accurately assess total sleep time, as well as break sleep down into various sleep stages. And in order to measure circadian rhythm, we took blood samples at 4 different time points. So 6, 12, 18, and 24-hour time points in one single day. And then we looked at gene expression of our core circadian clock genes, and those are period 1, 2, and 3, cryptochrome 1 and 2, BMAL, and clock, to see if there was an expression of circadian rhythm before the intervention started, and to see if exercise was able to alter that oscillation in those genes. So we did a pre and a post blood sample collection using quantitative PCR. What did we find? So exercise did significantly improve sleep in our population, and that significant improvement was seen in total sleep and light sleep mainly. And what was really interesting is that our control population had a decline in all aspects of sleep other than deep sleep. Now, that decline is non-significant, and we'll see how things play out as we continue to collect data. But exercise did cause a significant increase in total sleep time. For peripheral circadian rhythm, we did not see any significant expression of these genes or significant oscillation. Therefore, there was no circadian rhythm present in our patient population. And you'll notice the very high standard deviations at each time point. And sorry for the messy graph here. We had a lot of different genes for multiple groups. So there's a pre and a post for each gene for the exercise and control group. And the time points, again, 6, 12, 18, and 24, we did not see significant change in that gene expression. And the large standard deviation may be due to there's multiple different cell types in circulation in peripheral blood. We weren't able to isolate out different cells because we only had 100 microliters of blood in our sample. And so in the future, we want to try to isolate different cell types and see if those oscillatory rhythms become more consistent, as well as different cancer types, because there's a lot of literature saying that, or that show that different genes tend to be upregulated or downregulated in different types of cancer. So being able to screen that out once our sample size increases may paint a different picture. And then body composition. So body composition before and after, and this is just for our exercise group, actually maintained the same. So there was no significant change. We see a trend of an increase in skeletal muscle mass and then a decrease in body fat percentage. We'll see how that plays out as we continue to collect data. The one big limitation of this study is that we did not have a control population doing the InBody assessment. But it is encouraging because as we know, there are a lot of cancer patients as they start going through treatment. So again, our participant population was currently going through chemo and radiation. And when that when that treatment regimen starts, a lot of patients will lose body weight, lose skeletal muscle mass, and increase body fat. So being able to maintain that is very encouraging. So in conclusion, exercise does significantly improve quality of sleep, and that improvement is both necessary and sufficient to avoid a decline in sleep quality that would present from starting chemo and radiation. The attenuation of a potential decline in body composition, again, is very important and encouraging for these data, and to continue to encourage the use of exercise when patients are going through treatment. But a lot more research is needed in order to assess the effects on peripheral circadian rhythm. Thank you very much. And I look forward to questions.
Thank you so much, Mr. Krinsky, for sharing all your doctoral research with us. Very interesting results. Next, we're going to watch a video shared by our next speaker, as she was unable to join us today. Ms. Lori Braby is a master clinician occupational therapist for over 20 years at the Shirley Rand Ability Lab in Chicago, Illinois. She has developed a strong focus in treating the neurological population, vision, cancer rehabilitation, and chronic pain. Her most recent research interest is focused on using modern bioimpedance analysis to quantify subclinical and clinical breast cancer-related lymphedema, identifying patients in the reversible stage of the disease. She serves the rehabilitation community through invitations to the national advisory panels and has served on the board of directors for the SCIA Illinois from 2013 to 2016, and has also published chapters on brain injury, stroke, and neurodevelopment conditions. Now, I leave you to listen to Ms. Brady's presentation. It's a little longer than the 20 minutes, but I guarantee to you it's going to be worth your time, and it will be very interesting for you. Thank you so much.
Different amounts of lymphedema measurement will help us with staging. Lymphedema, are they stage 0?
Sorry about that.
0, are they healthy? Are they stage 1? As we know, 0 and 1 are reversible. So those are really critical stages to catch patients in for lymphedema, so we can implement treatment as soon as possible. So the staging affects the treatment protocol. Are we doing an early intervention protocol? Are we doing a reduction protocol? Maintenance, what does that look like? We also quantify lymphedema for compliance reasons, to give the patient feedback, to let them know what progress they've made or what progress they haven't made if there's someone who has a difficult time following through with home programs. Outcome measures, obviously, we want to make sure that we're using evidence-based outcome measures as part of our justification for therapy and our treatment. Reimbursement purposes, of course, with insurance to justify how many sessions we need for patients, or return surveillance or maintenance programs, and then ongoing surveillance. So these are all reasons why we want to make sure we have a reliable and sensitive system for quantifying lymphedema. So what are we actually measuring? The traditional approach is to use tape measurements or volume measurements. And so a lot of times what that yields is information on the total volume, especially with tape measurement, of the whole limb. So if we look at the center picture here, clearly this is depicting one extremity with lymphedema versus one unaffected extremity. If we measure using a tape measure, we'll obviously get a larger volume of this arm, but it really won't tell us, is it true lymphedema? Is it adipose tissue? Is it muscle mass? This is a really good reason for looking for other options for measuring or quantifying lymphedema other than just tape measure. A newer technology that we're all familiar with since we're here today is bioimpedance analysis. And as we know, InBody has several different options that clinics use. Our clinic specifically uses the InBody 770. So this machine is really great for multi-frequency bioelectrical impedance analysis. And this machine will give us information outside of just total limb volume, which is what we would get with the tape measure. And so we have the added benefit of having information on the fluid volume for the limb. So extracellular water separated out from intracellular water. And as we know, lymphedema, when it accumulates in the extracellular space. And so those ratios are really the focus of the biometric data that we get from the reports through using the 770. We also take into consideration the intracellular water numbers along with the dry lean mass and the body fat mass, because we could be accumulating more intracellular water for these different reasons. If we're doing a lot of strengthening with the patient, we might have muscle bulk that we're considering that could be holding on to more intracellular water that could potentially artificially affect the extracellular water ratio. So we take all of this into consideration with each case. And it's really unique to the InBody products to have all of these different biometrics as a clinician when you're trying to assess what's really going on with the patient, instead of just a number that's calculated for you without having access to the true data behind each case within each limb. This is really critical to our practice. We have a little checklist here. This is a checklist that I used for myself when I was deciding which technology the Shirley Ryan Ability Lab should invest in. And we did research both of these products for a minimum of 6 months, actually. And there was, in the end, we realized that having access to all of the biometrics I just described, including, not the segmental values for the extracellular water over total body water ratio, or the impedance ratios, or the phase angles. These are all types of data that we have access to because of the technology with the InBody versus the competitor, which just gives you a single value and puts the patient into a range of healthy or at risk for lymphedema. So 2 cases we'll talk about. The first case was a woman who I worked with for several years. She has a history of breast cancer that was diagnosed in 2008. I have a summary here of her medical care combined with her therapy history. She started at a different outside clinic initially. She was diagnosed in 2008. She didn't have symptoms until 2010, initial symptoms for her lymphedema. She was treated at an outside hospital with daily lymphatic massage, over-the-counter compression, so circular knit compression, and was educated to just wear that with travel only, not with any workout activities or cardio activities. I should point out that this patient is someone who's very physically fit. So it was important to her to get feedback about how her biometrics are changing as a result of treatment, but also working out. So you could see that InBody data would be very useful for this type of patient. I began my treatment with her in 2018, so 10 years after her initial diagnosis. She didn't have any problems for a good 8 years with her lymphedema until she had these 2 minor incidents within 1 month time period. They were very small when I saw her in clinic for the evaluation. The small burn that she did have on her hand was fully healed. And the other example was she could recall one incident of pitching her hand while she was working out between 2 weights. So they, might seem like innocent incidences, if you will, regarding a lymphedema exacerbation. But both of these, especially the burn, both of these encounters really created an environment for increased inflammation. And so with that, we know when you have a reduced lymphatic transport capacity, that will put you at risk for your body to have difficulty managing the fluid associated with any inflammation. So when I met with her at her initial evaluation, this was in July of 2018. At that point, we did not have the InBody, and so we only had access to tape measurements, which was the standard of care at that point for our clinic. And so if you look at the summary here, we have her affected, versus her unaffected side. And there was an 8.2% difference initially. She did decline bandaging because a lot of this fluid was maintained in her hand and her forearm, and she didn't want to compromise her workouts. So, after a few weeks, it was about a month of not seeing a significant difference, the patient was finally convinced to have her arm bandaged. I think we bandaged a few times, maybe 3 times. And then we did see this reduction using a tape measurement, volumes back down to a comparative volume almost identical to the unaffected arm. At this point, she was discharged from therapy with a flat neck garment, which was an improvement for containment purposes, as opposed to the over-the-counter garment that she had from her previous clinic 8 years prior. And I did recommend compression class 1 because she's a very tiny person. Her wrist circumference was like 14 centimeters. She was just really tiny overall, like 5-foot frame. And so with that, we came up with the solution to switch to flat knit, but keep it at compression class 1. So fast forward a year, the patient did return in November the following year with increased volume again. She had gone to Europe and had an exacerbation as a result of the air travel. And so she did not wear her sleeve for this, unfortunately, for the air travel. And she felt like, she had managed her lymphedema for a year and a half, and she was going to self-discharge using the sleeve. She had this exacerbation, returned to me. We measured using tape measure. Again, you can see the difference. We have almost a 15% increase in volume. She agreed to treatment. We did wrapping. She came back down to almost identical limb values using tape measure again. This time we discharged her with a flat neck garment, but compression class 2 to help with containment properties. And so she did wear the garment regularly at this point during daytime hours. In 2020, she pursued the lymphovenous anastomosis and lymph node transfer microsurgical procedures in Chicago here, and she returned for treatment after that. And I have a summary of her limb volumes in addition to some biometric data from the InBody. It was at this point during her return to the clinic that we had acquired the InBody at Shirley Ryan Ability Lab. And so we were able to use this technology to further extrapolate what was going on in her left upper extremity and her affected limb. And so what we saw was very interesting, and that's why I'm choosing her case to highlight, because we do see these kinds of cases all the time now that we have the InBody. But this is really a great case to try to highlight the differences here, because if you look, her limb volume using tape measurement looks terrific. So her unaffected and affected arms are essentially the same. However, when we did the InBody, we were able to detect an increase in the extracellular water in her affected arm compared to her unaffected arm. There's quite a significant difference there. We did wrap as a result because the cutoff value for 0.385 would suggest that the patient is quite possibly in the stage 1 zone, not even stage 0 at that point. And so she was agreeable to wrapping, which we did. We repeated measurements again in January of 2021, and we had somewhat of a decrease. We kept doing treatment again, and we had finally came down to 0.379 for the extracellular over total body water measurement for her left upper extremity. And so that gave us confidence to discharge again using the flat neck garment on a daily basis. But we had the benefit of using the InBody to reinforce the wrapping that we wanted to do with her. This is just another summary here of how we looked at the InBody data versus the tape measurement circumference. So we have, if you look at the bioimpedance column here, we have the different stages based on her extracellular water over total body water ratios. So here we have stage 1, whereas if you might look at the tape measurement, it might suggest that she was not as severe as stage 1. And then also we started using, this is the other piece of data I want to emphasize here. The extracellular water over total body water is just one piece of data that we've learned to use. At first, keep in mind, this case was someone who I started following as one of the initial cases once we got the technology. And so it's been a learning experience. Monica's been very helpful as my contact on the US side of things for clinical questions and care, try to help tease some of this out. But we used to put a lot more emphasis just on the ratio for the limb instead of the extracellular water over total body water ratio. But then we were seeing some differences with impedance ratios too. So if we look at the two different ratios, we'll see that even though if we look here at discharge, we were in a normal range for the extracellular water over total body water ratio. If we look here for the impedance ratio, we still were coming out a little bit on the high end. So 1.12 would still put the patient as a stage 1 that was confirmed. And this is really important because even though the two ratios might seem like there's a discrepancy there, we have to really take a step back and use this data to provide the most conservative recommendations for the patient. And because this is an evolving technology, we're very careful to explain to the patient and within our own clinical conversations when we're deciding treatment, that we don't have many years of data on these patients yet. And so we have to look at both ratios. So there isn't just a very clear treatment protocol based on the extracellular water ratio compared to the impedance ratio. You might have a discrepancy there. But if you have been seeing a patient for a while and you know that they have these fluctuations, and I look at this data here that says one of the values is showing that you're in the normal range. However, the impedance ratio is showing that you could still be in stage 1. We should consider being more conservative and using your sleeve ongoing. And this was important because the patient, every time she came into therapy, she was asking if she could discharge the sleeve. However, back in the first slide of this quick presentation here, I was sharing one of the reasons we do want improved quantification of lymphedema is for patient consistency and to have them carry over the recommendations, have concrete information as to why they should still wear a sleeve or why they should continue to come to therapy for bandaging if needed. And this was the perfect example because the patient was reinforced, or our recommendation was reinforced with the patient when we were able to demonstrate that the impedance ratio is still a little bit high and we just don't want to take a chance that she would have another exacerbation. And the patient was agreeable to that. And we continue to do ongoing surveillance with her. This is just another chart of her biometrics. You can see here, if we looked at just the traditional staging for lymphedema based on tape measurement, it would have suggested that she was in a healthy range, whereas the staging using the InBody bumped her up into the stage 1 range, which is more consistent with her presentation. She does present with persistent edema, lymphedema in her hand and her lower forearm. And so this is really important to acknowledge because if you look at the overall tape measurement for her entire arm, she was coming out almost equally because she had a larger bicep muscle on the left side, which was artificially increasing the overall tape measurement or limb volume for that affected arm compared to the unaffected arm. So, it's really important to acknowledge the it's convenient to do tape measurement. Many physicians are most comfortable with tape measurement. Insurances are comfortable with tape measurement. However, it's not the most sensitive type of technology. It's not a technology, right? It's not the most sensitive method of measurement for lymphedema because it's not separating out extracellular water versus intracellular water, muscle mass, and fat mass. The second case study I want to take a few minutes to go through is a little simpler. It's a patient that I just saw in clinic as a return visit. I first met her in 2019. She's also a breast cancer patient. When we first met, her lymph volume was essentially equal between sides. Her affected versus unaffected was only a 30 milliliter difference. I did discharge her. She was very active. We didn't do any reduction therapy for her, but I did discharge her with a flat knit compression class 2 garment because of her activity level to help with active hyperemia and increased demand on the lymphatic system when she was playing tennis. She did continue with her workout routine for 3 years on her own. She regularly wore her flat knit sleeve. She felt she had good containment with that. She only wore it for working out and air travel. Eventually, she decided to purchase her own over-the-counter sleeve and transitioned herself into that without my knowledge over those years. She reports that she felt stable in that, which is her own decision. She didn't have any concerns. Eventually, she discharged all of her compression during workouts, and she justified that because she switched from tennis to pickleball. She thought it was less aggressive for her arm. And so as a result, she stopped wearing compression altogether. In 2022, so just a month ago, the patient contacted me because she had been seeing a private massage therapist on the side who reportedly is trained in lymphatic massage. This therapist brought to her attention that she thought she suspected through palpation an increase in fluid volume in the upper arm portion of her affected arm. And so she requested to come back in for a formal evaluation. At this point, this is another patient who initially we only had tape measurement values for. She then returned 3 years later. Now we have the InBody. So we did we did take advantage of using the InBody 770 to get more specific quantification of what's going on in her arm, whether it's lymphedema or not. And so what we saw, we repeated the tape measurements, and they ended up being a lot less overall compared to her tape measurements in 2019. Possibly she lost weight. It's hard to say. That's the most likely reason. Both sides are equal. We added the bioimpedance analysis to the evaluation here, and you can see the extracellular water over total body water ratio came in at 0.381, which is healthy, so that was great. Her impedance ratio also came in on the healthy range, 1.0. However, what we noticed, was that the fat mass came in at 4.2 pounds. Now, we did not have an amount to compare this to from 2019. However, the 4.2 pounds for her right upper extremity is 200% of what the age norm would be for fat mass. So even though this woman was quite active, she did have a high percentage of fat mass in that arm. And so as we know, when we have patients question what they're truly palpating, especially in their upper arm region, saying that it's lymphedema makes us feel like it's less of our responsibility to have to worry about as patients, right? But at the same time, it's important to know if it is potentially fat mass, because that is obviously not the same kind of health risk as lymphedema would pose for the patient. And so we did discuss that is a likely reason for her to feel this increase, which what her therapist was describing as fluid volume, and really it was actually just some very likely fat mass. So that's another good example of how we use the full report, all of the biometrics, not just the fluid ratios and the impedance ratio and the phase angles, but also looking at the fat mass and muscle mass. For this patient, it was important to acknowledge that and let her feel comfortable that actually she probably is doing okay without wearing the garments, even though I did reinforce for someone who's at risk. She did have a full axillary lymph node dissection back when she had her initial surgery. And so she does remain at risk for lymphedema exacerbation. She should continue to wear her sleeve, especially with cardio like tennis or pickleball. There really would be no difference in terms of the increased fluid circulation or active hyperemia and that increased load to the lymphatic system. So we did review those recommendations.
We are very grateful to Ms. Bravi for sharing her exercise with us and the video that I hope was very insightful for everyone. Now we're going to go into our second break, 10-minute break until 10:30. Please join us back here after the break for more talks and our panel discussion and Q&A. Thank you. Welcome back. Our last speaker today is Dr. Gabriel Alexio, who will be talking about sarcopenia and its implications in cancer care. Dr. Alexio is a third-year internal medicine resident at Cleveland Clinic, whose research is focused on the impact of body composition parameters in cancer with more than 20 publications. Please, I want to remind you to add your questions to the Q&A box on your screen. And if you want to address your questions to a specific speaker, please note that in your submission. Without further ado, I'd like to welcome our last speaker for today, Dr. Alexio, to join.
Okay, thank you so much for having me here. I will share my screen and I hope it works. Did it work? Is it working okay?
Yes, we're good. Thank you.
Okay, good. So thank you so much for having me here. It's a real pleasure. It was fantastic to see the presentations and so many common interests in body composition. Without further go, I would like to start talking a little bit of body composition, just to remind a little bit, like up until in 1916, this article from Dr. Dubois, 1916, he proposed the body surface area, which is up until today, 2022, used for chemotherapy dosage. And I think we should start thinking about other more accurate and more precise measures. And that's why I have been so interested in the study of body composition and their multiple implications. So I know that it has been extensively talked here. So what is sarcopenia? It is actually the loss of muscle mass that accompanies aging. It is something that is normal in people, and as you know, as long as we are getting older, we are losing muscle, and that's pretty normal. It starts on the fourth decade of life, and there is a linear decrease, as it was already shown here today, in loss of muscle mass and strength. It is associated with functional impairments, with disability, with increased risk of falls, fractures, reduced health-related quality of life, and increased risk of death. And there is an estimate of $18.5 billion cost per year of sarcopenia in the United States. And there's a lot of some people that are not involved in this type of research always get confused with what is sarcopenia, what is cachexia, and what is frailty. And this table, which is in a brilliant article from one of my colleagues, Dr. Grant Williams from UAB, shows it very interestingly that with sarcopenia, overall body weight can be actually the same. People can have normal body weight and not be losing weight and still have sarcopenia, as it is something that accompanies normally with aging. Also with sarcopenia, differently than frailty and cachexia, you don't have inflammation. Fat mass is like in cachexia is decreased, and in sarcopenia you don't. Muscle strength is decreased in all of them, but that's the main difference. The body weight is still maintained in sarcopenia, and that's why sometimes when you see a patient in clinics, that patient has a normal BMI or sometimes even an elevated BMI, but in fact this patient can be sarcopenic. And what is the study on sarcopenia in cancer? I mean, since 2015, and when one of my colleagues, Dr. Shokar, published her systematic review and meta-analysis, the interest in sarcopenia has grown exponentially. But despite that, still the majority of the data that we have are retrospective. It has been shown that sarcopenia increases the risk of recurrence, cancer-related death in gastric, breast, urothelial, colorectal, hepatocellular, and hematological diseases. Sarcopenia is related with poorer prognosis, with hazard ratios ranging from 1.1 to 2.2. And this is also seen in early breast cancer, which has been a lot of also my interest. So this is actually a table that me and my group published with a systematic review showing that in early breast cancer, it's still kind of unclear if sarcopenia is or is not related with overall survival, taking into consideration that patients with early breast cancer usually survive a lot. The survival is over 95% nowadays. So how is the diagnosis of sarcopenia? I know that this has been already spoken here about. Most of the studies in cancer utilizes CT scans. They also use DEXA scans or MRI, ultrasound. That is this delta-8 creatinine, which is promising, but still only on research, and the BIA. And now, I can tell about the CT scans and what is the problem with the CT scans? Most of the studies using CT scans, they use like a software, a special software, like a Slice-O-Matic is one that is most of the research has been used. And it's quite hard nowadays to use that in clinical practice. Just because to use like a Slice-O-Matic, you can't use the images from Epic. You needed those images to be in a DICOM file, and so it requires some kind of like time, and it's not so readily available for everybody to calculate and to know sarcopenia. That's why BIA turns out to be so interesting. And it's also interesting to use BIA in a setting of cancers that you don't actually get so much CT scans as in early breast cancer or in some hematological malignancies such as AML. So that comes to BIA in cancer. Me and my colleagues, we wrote this systematic review of bioelectrical impedance analysis in the assessment of sarcopenia in cancer. And we actually didn't, it is now almost 3 years, and we didn't see it being widely used. I know that it's increasing the use, but there are some things that I think that limit, and we are going to talk about in the future thoughts for this area. BIA can actually estimate muscle mass. It is, as I said, more used in like in cancers that don't require CT scans. And I mean, it's so easy, as most of the people here know, to use it. You know, and in our latest study, we show the correlation between CT and BIA of 0.62 in patients with early breast cancer. And that was published in Breast Cancer this year. And I'll talk more about this. So sarcopenia in early breast cancer, which has been a lot of my interest, as it has been spoken here today, patients with early breast cancer, they have a very long survival. Now, these women, usually they are pretty, you know, healthy, but we give them like chemotherapy, and sometimes we give endocrine therapy, and they ended up suffering a lot from toxicity. And this is something that really interests me, like in clinical care. And our study is actually one of the first ones to show the association of sarcopenia in early breast cancer. And we showed that patients with sarcopenia who were receiving endocrine therapy, that means like anastrozole or tamoxifen, they had much more toxicity from those medications. And this toxicity comprised from grade 3 and grade 4, so very debilitating toxicity of arthralgias or hot flashes, also cardiovascular toxicities, fatigue. So we made a combine of toxicity, and we saw that the odds ratio was 2.44 with a p-value of 0.006 for patients who had deemed sarcopenia, using, of course, the guidelines from sarcopenia. We also saw that patients that were obese also had this higher grades of toxicity. And this is like similar to what has been shown in the study from Vatican with over 3,000 patients at Kaiser Permanente. She didn't do actually in with regards to endocrine therapy. She did regarding to chemotherapy, but this is actually similar, because those patients that were overweight, we did not see that relation, that association. And this was the same thing with early treatment discontinuation or change. Also, patients who have sarcopenia had early treatment discontinuation. And for those clinicians that work in a breast cancer clinic, I mean, those patients, they are pretty healthy usually. In our cohort, over 90% of our patients were either obese or overweight. And so it's usually like a woman that comes and has like a normal life, is usually very healthy, and we are giving them some medications that cause like pretty bad side effects. And if we could know more of what would be the predictors, that would be really interesting. And this article was actually, we had data from this at the last ASCO. In last ASCO, it was published there, and also it was published in BCRT this year. Also, from the same cohort, using 322 patients, we did an analysis from using detecting sarcopenia and seeing from these patients, those who have more dose reduction, early treatment termination, hospitalization, and interestingly, neuropathy. So those were patients who received chemotherapy for early breast cancer. The interesting thing is like neuropathy. Those patients really suffer when they get, especially like ACT, which is a combination of chemotherapy for early breast cancer. They suffer a lot from neuropathy. And we saw that patients who had sarcopenia had more neuropathy, they had more hospitalizations, they had more dose reduction, dose delay, and they had more chemotherapy toxicity, as seen below. The toxicity that we analyzed were also grade 3 and 4, so severe anemia, also some cytopenias, yeah, those were the main toxicities that we were looking. This was also seen true in patients who were obese, again following this similar results to what Dr. Khan found in her study at Kaiser. Now, currently, we are working in a prospective study to analyze. So sarcopenia has so many like implications. A lot of my research was on patients with early breast cancer, but I also have been interested in working with patients who have hematological malignancies and are deemed to receive allogeneic stem cell transplant. Some of those patients don't get CT scans. Those patients with AML, they usually don't get CT scans. So that's why we are doing a prospective study to determine if patients with hematological malignancies who will receive allogeneic stem cell transplant, those who have sarcopenia, if they're going to have less tolerance to treatment, if they're going to have more side effects, more hospitalizations, and lower overall survival when compared to patients with without sarcopenia. This will be a prospective study. The IRB was just approved, and we are gonna follow these patients. Our hope is to get like 100 patients here at the Cleveland Clinic and follow them to see how they will do. And that's one of the part of my interest, is to increase prospective data in order to I think that this will improve the quality of what we already have. Now, some of my thoughts, me and my mentors, of what is the future of this field. I've seen very interesting presentations on exercise therapy and how we can approach sarcopenia. I think that this is one of the things that we can actually do, and actually to bring this to clinical practice. My thought is that we need things that can be done to address that. And prospective data is needed, as most of the data is retrospective. And randomized trials, which will provide that screening sarcopenia prior to treatment will reduce side effects, improve quality of life in patients. So those basing on using sarcopenia or using other body compositions is actually needed for us to bring this to clinical practice nowadays. This is something I have been discussing a lot with my mentors, Dr. Haimas at UNC, Dr. Grant Williams at UAB, Dr. Hale Moore here at the Cleveland Clinic. And until we have a way to approach those patients and to show that if we screen for sarcopenia, those patients are gonna, and they get like less chemotherapy, they will have less side effects, then we can bring this to clinical practice. This is one of my thoughts. The same way, if you have an elderly patient who does not have sarcopenia, maybe you can give a little bit more chemotherapy for these patients, and they will eventually benefit from that. So I think that the future of this field is so interesting, and I was very pleased to see so many people working and doing very interesting research. And I will finish my my presentation with some key takeaways. Sarcopenia is low muscle mass. It can be a normal a normal process from aging. Sarcopenia negatively impacts patients with cancer. BIA can be an effective way to screen for sarcopenia and can be one of the ways that we can actually put this into the clinical practice due to its easy method to assess it. And definitely, we need RCTs and prospective data for bringing this from the research field to the clinical point. I really thank you so much for the opportunity to be here. I have to thank you, all my mentors and people who helped me from UNC, from UAB, from Cleveland Clinic. And here's my email if anyone has questions or comments or anything. I'll be happy to answer or try or collaborate. I'm more than happy. Thank you so much for the opportunity. Thanks.
Well, Dr. Alexio, I want to really thank you for an amazing closing talk. And now at this point, I would like to invite all the speakers to join me for a panel session. So if you can please put yourself in the picture and unmute yourself so we can have a nice conversation between us. Thank you. Okay, so let me stop sharing because I want to see all of us in the screen and that everybody can see us discussing here. So we have been having different talks, I think, about exercise as medicine for cancer patients, sarcopenia, skeletal muscle mass measurement. I wanted to actually give the opportunity to one of you to probably ask a question from another one of your colleagues about their research and how do you see, you could collaborate, you can think about different options, things like that. So I'm opening the floor for anyone, and if not, I'll start with something.
Well, I mean, as a clinician, I think, part of the question is getting patients to our exercise facilities is a major hurdle. and then of course getting it paid for. Right. And then third is making sure it's an adequate dose. So our big push is that a lot of this really should be in person, not at home. And I know people will argue with me about that, but we have every woman in our facility, whether she's 30 or 90, is hex bar deadlifting. So I don't want them to do that at home. I want it to be under our guidance. So I think that's a major component to this. And then lastly, of course, is measuring everything we do, right? If we want to show people that exercise is medicine, it needs to be measured.
I have a question, Dr. Champ, about what is the data available on sarcopenia and early breast cancer with regards to radiation therapy? Is there any relation? Is that any association or any data available? What would be interesting to know? Thank you.
Well, the elephant in the room, before I even answer, the elephant in the room is that for most women with early stage breast cancer, if they get radiation, we're doing partial breast, so we're radiating an area about that big. So you hit on this. We really should not, and this has been our push. I don't think we should view early stage breast cancer, women with early stage breast cancer, any different from the normal population whatsoever, besides treatment related issues and that they are at increased risk of bone density loss. So we actually need to load them more than the normal population. But early stage breast cancer, the radiation will have minimal effect in regards to sarcopenia. There are some other sites where we've studied it that shows a relationship with sarcopenia. But again, for early stage breast, we're not even doing whole breast radiation much anymore. So we have no excuse to get these women to the gym and load them with the methods we would use for professional athletes.
I just want to add that I agree with you, Colin, regarding in-person exercise. It's certainly a modality that I've used, and until moving to Boston, I would exclusively run clinical trials in person. Here, it's been a little bit more challenging. We have a lot of out-of-state patients, so we've tried to accommodate that as best as we can. But my challenge with that is really, I think that we all know exercise is good, right? Physicians know exercise is good. The general public knows exercise is good, but there's still something missing to where in-person exercise is and probably always will be less feasible. And so I'm always challenged whenever I give a talk about clinical exercise about, well, this isn't real life. You can't do this elsewhere. Nobody lives really next to Dana-Farber or other places to be able to get to in person. So, but I appreciate that you as a medical doctor has this position, because from my perspective, when patients join our trials, they're more likely to join and stay on trial when they have the support from their oncologist. And that message is just not delivered across the board. And that's really the part that we struggle with. I don't know that physicians, that you all know how much power you have to get patients to move, because we've seen it in our lab. It is really, really impactful. It goes a long way.
You're 100% spot on. And we've actually seen that in our own facilities. The facility in Florida, there's not always a physician there, and the adherence rates are not as good. Whereas our facility in Pittsburgh, half the time I'm there coaching people. And so I'm bantering with them. I'm busting their chops. We're making fun of each other. And we actually have a wheeled sled that we got. And I asked the group yesterday, will you all do the sled at the end of the workout? And they said, are you telling us to? Because if you're telling us to, we'll do whatever you say. So you hit the nail on the head. We need to get doctors involved to make the prescription, right? And then, you all can take over from there. But yeah, I agree.
now that you have all talked about, how important that exercise is, now one of the things I'm wondering is, this is not a generalized, approved, insurance paid treatment. Do you see, or a way for it to get to that point through collaboration, talking more about it? How could we get to that point, to where it would be approved for every patient, so it is also more reachable for them, right?
I don't want to hog the mic here, so I apologize, but as our gym is funded by Blue Cross Blue Shield, I can tell you that in my experience, insurance isn't going to pay for exercise as long as it's this amorphous exercise, which means anything from walking on a treadmill to owning a membership at Gold's Gym and maybe going, maybe not. It has to be prescribed with metrics, right? There's a reason physical therapy has such a stronghold on this, because there are CPT codes to pay for it, right? If we show what we're doing, I mean, look at Christina's slides, right? This is what we're trying to do. These are the results. Here's the muscle mass that we built. A lot of the older studies didn't see benefits there because the metrics that the methods that were used were not those that would see that benefit. So we have to follow. That's why I keep saying we have to follow. What would $1 million professional athlete pay us tons of money to do? We have to. It's the same metrics that we're doing for cancer patients, right? So we measure it and we show, hey, look, we can affect this, and then we get enough people showing that and doing that around the country that we run a 5,000 person study at every sports performance facility around the country, and then they'll pay for it.
Yeah, I'd agree. I think it really comes down to continuing to study this and to study like similar modalities of exercise, and to be able to, paint a picture for insurance companies to show, like, based on somebody's cancer type, somebody's treatment status, what is the modality of exercise they're going to be doing, and be, more specific on what, specific benefits come from what specific types of exercise.
I think that the challenge, though, is that we already know so much. I know there's a lot in the biomarker space that we don't know about, like anti-tumor effects. And I know there's a big movement for treatment toxicity with the NCI and NICTO trials. But how much more do we really need to convince people that this is impactful? I mean, what do we actually need? I don't know. I think this is a huge policy issue that is really almost even, I would say, I mean, I don't want to say beyond us. I think we are all contributing and showing the data, and we'll continue to show the data. Otherwise, I won't have a job. But, it's exercise is good on so many things, reduces hospitalizations, reduces length of hospitalization stay, infection. I mean, there's so many metrics now that, what more do we need aside from that exercise will cure cancer? I mean, but that's, obviously totally out there. So I really think it's a policy issue, and just maybe even crosstalk between medicine or oncology, exercise, and policy, just having the right players to push this forward. I know ACS is involved with a lot of this, having support, maybe even stronger support from organizations like ASCO. They obviously have their own some guidelines around this, which is fantastic, but that's like going back to the message where physicians buy into this. I think is just going to continue to be a really great avenue for this. I love that your gym, Colin, is supported by Blue Cross Blue Shield. That's amazing. And if that model were everywhere, I mean, that would be incredible.
We'll all keep pushing the good fight.
Mm-hmm.
Yes, definitely. I guess that would be ideal if we could do a study with, 10,000 patients, right, or from all different universities. That will be hopefully give enough numbers to create something like that. So I really appreciate all the work all are doing towards that. I think now we have several questions from the audience. So let me probably start doing that right now. And at any point, if, you know, they're all directed at each of the individuals, but if at any point you have something that you can answer or add to it, please, you know, that's why we're all here in the panel, so we can all add to the discussion. Okay. So the first question we have, either for Dr. Diele-Conright or Dr. Alexio, is I see that both of you have used different body compositions methods in your research, in your work. How do you decide which one to use in each study? Is it dependent on the treatment that you have, is happening for the patient? And have you looked at combining modalities in order to take advantage of the pros of each assessment method?
So, I mean, I think that it depends on what do I have the data. I mean, most of my research up until now is retrospective data. So like if I had CT scans on the patients, I try to use them to see the sarcopenia. But when I had bioelectrical impedance analysis, I used that to see, and I did a correlation between those patients that I had a CT scans and those patients that I have bioelectrical impedance analysis. I think that you know, that's what I've done with a retrospective, but you know, the good thing of the BIA, when I thought about this prospective trial that we are doing with patients that are going to receive allogeneic stem cell transplant, is that they don't get CT scans. And we, you know, and so the bioelectrical impedance, it's so easy. And I mean, yesterday I was talking in North Carolina about the use of bioelectrical impedance analysis, because I think for the clinical oncologist that you can have, you know, a machine and in your practice, as now you have like a BMI before you see a patient, you're going to have all these data. But that's the question that I always talk with my mentors, like, until we have something that we can do with this data, like either like exercise or adjust dose or nutrition, or like, you know, something that we can do to that, it's going to improve either quality of life, that less toxicity, you know, then this is you're gonna have this widespread. Grant Williams is doing like a prospective study with oxaliplatin in patients with colorectal cancer. So this is like a beginning. I think you know, we are in the phase of retrospective, and maybe in the future we'll be in the front. That's what I hope.
Yeah, I would just add that we choose a modality often based off of what we can afford and where body composition is throughout our endpoint continuum, if you will. So we try to select the most precise body composition endpoint if that's our primary endpoint, and invest dollars there. But from just a pure research standpoint, it really comes down to how much money we have and how much burden that we can allow for the patients. Because while it might make sense to combine two different modalities, you know, based off of how our facilities are organized, we might have to walk to a second building to go get DEXA versus another one to do something. So I would say definitely resources as well as patient burden is what we think about.
That makes a lot of sense. I want to ask you something else also. It seems the recent consensus is that precachexia, less than 5% loss of body weight or lean body mass, is a better indication to start treatment for many patients. Have you also seen in your patient population that while in the immediate 6 months, there's weight gain but substantial muscle loss before diagnosis? And Can you speak of a multimodal approach to precachectic care? So when you have this kind of patients? And I don't know, who wants to take the...
I mean, cachexia, you're going to see more in like patients with pancreatic cancer, like those patients, like they do have, you do serial CT scans in those patients, you're going to see like they lose muscle mass, they lose visceral adiposity, they lose subcutaneous adiposity, they lose everything. There are some approaches that some places are doing still, like lots of research, but usually like you know, exercise, diet improvement. You know, it needs to be like a collaboration between. That's what I have been seeing in studies that take, you know, those types of like GI cancer. So you get like colorectal cancer, pancreatic cancer.
Okay. Thank you so much. This question is for Dr. Dialli-Conright. Beyond looking at disparities in the disease treatment in Black men, have you examined disease treatment differences in Black men in urban versus rural settings? And have you seen differences in how body composition and other factors happen with this population?
I think I heard you correctly, but I'm not entirely sure. So the first question was related to urban versus rural.
Yes,
Yeah,
that's correct.
Unfortunately, I've only studied exercise within urban settings. So I haven't had an opportunity yet to study rural populations. So I don't have fantastic comment for that one. And then what was the second?
The second one is, have you seen differences in how body composition affects treatment, or are there other factors in the minority population? I know you were looking at metabolic syndromes, for example, in survivors. Do you have anything that you can share with us about other populations, or even this population that you talked about?
Yes, it's a good question. I probably can't answer that directly just yet, because we do have some ongoing studies tracking or with exercise during treatment. So it might be a question for Gabrielle or Colin with respect to treatment efficacy, if that's what that's getting at. But all of our studies right now in exercise during treatment are all ongoing with respect to minority patients. So my answer would be no, because we just haven't studied it yet. But I don't know outside of exercise, like we're not doing observational data at the moment on differences in treatment by minority.
Okay, thank you. Does anybody have anything to add about that, or have not had any experience on looking at those differences? No? Okay.
So I'm working with Dr. Williams, and we are looking in patients with pancreatic and colorectal cancer. They're at UAB, and they have like 25% of those patients that are African Americans, and we are going to look into their ethnical differences. Yeah, this will come soon. We still don't have the results, but it would be very interesting, you know, because if you look at for example, like the measure that everybody uses, right? So BMI people use for everything nowadays, despite being a very crude measure that doesn't take into consideration anything. For the Asian population, they do have a different scale for like overweight, obese, but for African Americans, you don't have that. And it's very different. I mean, from my clinical just observation, I have my primary care clinic at the Cleveland VA, and I mean, sometimes you have patients that they have a BMI of 31, but they're very strong. like how you're going to classify. Are you going to classify this patient as obese? So I'm looking forward for that.
Thank you so much for sharing that. The next question is for Dr. Champ. It says, in your article, you mentioned the body will engage compensatory cellular mechanisms. Beyond looking at body composition improvements in muscle, fat, and others, have you examined change in self-health parameters like face angle or body cell mass?
So we look at phase angle, of course, on the InBody. I don't know of any other way to do it. So we record that for everyone. And that's, of course, a metric that we know correlates with their cancer and their stage. So we've certainly seen that. And so we track that. And then in terms of, and Christina mentioned this as well, we have a proteomics lab that we could do blood samples for that, and metabolomics as well, which I think is it's a sexy thing to look at. I just don't know how much it actually, besides it's great to publish about that, I don't know how much it actually at this point impacts individuals, right? So of course, we're looking at these measurable outcomes that we could do, and we do an hour session to do all those things that we talked about, including movement screens and balance tests and whatnot. So in a non-invasive way. But sorry, I went off on a bit of a tangent there. Did I answer all the question?
No, that's perfectly fine. I know, yes, with treatment and with interventions, face angle can be an indication of changes. And I think with at the University of Northern Colorado, actually, Mr. Krinsky can attest that there's some studies that have been ongoing that hopefully will show some effects on that soon. I don't know if you want to share any of that.
Yeah, I know they just published that paper, or sorry, they just submitted that paper. And I know they found with exercise the improvements in phase angle. I don't know the data well enough to quote the exact changes and improvements that we saw, but and that was looking at patients that were currently in treatment and as well as post-treatment. But yeah, so look for that paper soon.
Perfect. That sounds good. And just to continue talking to Mr. Krinsky here, the duration of the study was 12 weeks. Do you anticipate that with longer duration, you may be able to see the circadian rhythm stabilize, as well as changes in body composition that may be possible at that point if you increase that duration?
Yeah, I think it's definitely possible. With the data that are out there, there are impacts on circadian rhythm from just acute bouts of exercise in the apparently healthy population. And I mean, the exercise intensity in these studies is above 60% of VO2 reserve, and we're not exercising that high with this participant population. But yeah, I do think maybe there's a time effect. We may see that if we stretch out that duration, and that is something that we are adding to the participants that are willing, an additional 12 weeks where we will sample another circadian rhythm sample collection after that. So that would be 24 weeks post. And as far as body composition, I definitely anticipate those improvements as time is a factor, just because most patients, as they discontinue their treatment protocols, we may see those improvements occur. So yeah, I do think that could play a role, and we'll see.
So now we have a question for all of you, if one of you can answer. Somebody's asking that they would like to have a deeper understanding about the connection between cancer and elevated extracellular water to total body water ratio. They're talking specifically about a 720, but it will be a similar measurement in an InBody device. I don't know if anybody wants to talk about a little about that. All right. I guess if nobody has anything to say about that, one of the things though in extracellular water to total body water ratio, and I think we saw that in the presentation about lymphedema, is definitely an information that can be used as is an indication of inflammation. So that is definitely something that you would use for that kind of applications for patients. Okay. And we can share different articles so we can, that you can see what the interactions are. Okay, the next question is for Dr. Alexio. You mentioned BIA is useful for the diagnosis of sarcopenia in early breast cancer and AML. How often do you find it's most effective or useful, and to what disciplines, to repeat measurements, assessing for the progression of improvement of sarcopenia in the clinical setting? So how often do you think it makes sense to make those measurements with BIA, to follow the treatment, how effective it is? How often do you need to repeat those?
Yeah, that's one of actually the questions that we want to answer with this. So basically, on the study, we are going to measure at the time of so just a brief talk of for allogeneic stem cell transplant, those patients get they come to the hospital to get and they get a very strong chemotherapy regimen, which will basically destroy their bone marrow, and then they will receive a bone marrow from another person to try with the intent to cure their hematological malignancy. Now, obviously, these patients need to be in the hospital because they're going to be without any defense, and they can have pretty bad side effects. They can have infections. They can have they can suffer a lot. They can lose weight. Now, we don't know if they are going to lose muscle or not. So that's the interesting thing. So we are going to do at some time points are important for these patients. One is just before they receive that chemotherapy. So we will know what is their baseline. And then we are going to see how do these patients do in the day 100, which is the day that actually sets up if this patient is actually is going to do well or not. And then we are going to see it at 6 months and 1 year. So we are going to the interesting thing, at least from our perspective, is to see if those patients that actually lose more muscle mass will do worse. Are they going to have more hospitalizations? Are they going to suffer more? Are they going to have more infections, or have more problems? We don't know. So we are going to do at this time points together with geriatric assessment, which it's already a practice here at the clinic, and some measures from the geriatric assessment to look for frailty, such as the time up and go test and the 2-minute walk. So we are not going to only see sarcopenia, we are going to see how these patients are actually going to do. Yeah. Thank you.
Thank you so much, Dr. Alexa, for that. Let me see. We still have a lot of questions. There's one more for Dr. Alexio here. Have you examined the correlation between CT and BIA based on different body compositions? For example, does a certain range of muscle mass have a better correlation between the two apparatus?
So the correlation was 0.62, and that was in the continuous variable. So when I use the cut points, from from the data that the Society for Sarcopenia that uses the data in the regular population, I think they use 40 for women is 38 centimeters square per meter square. That's how much they use. I think that's it. And we used for the bioelectrical impedance analysis 6.75 kilograms per meter square. So when we use screened, like for sarcopenia, the correlation was not good. The correlation was 0.62 when we used a continuous variable. Now, that can be something to think about, but when when we use the sarcopenia, the measure sarcopenia from BIA and the measure sarcopenia from CT scan, and we did the association of those in we did the association with the outcome. So like dose reduction, toxicity, early treatment termination, hospitalization, and neuropathy, the use of BIA was actually better. It was like, we can't say that BIA is better, but BIA was more, had more associations with outcomes. Now, that being said, we had 332 patients that got a bioelectrical impedance analysis, and we only had 108 patients that got CT scans. So that can be just by that. So we can't say that BIA is better, but we can say that in our population, that were the findings, and that is in the article.
Okay, that is very helpful. One last question, and I think this is for all of you, whichever wants to answer. What percentage of patients are able to tolerate light exercise? And have you seen tolerance and pain levels related to cachexia? I'm not sure if you have seen cachexia actually at your clinic.
I would argue that everyone can tolerate some level of exercise. It just depends on their level. And I would also argue that most cancer patients can tolerate much more exercise than we think we can tolerate, or sorry, that we think they can tolerate, and certainly that their physician thinks they can tolerate.
Thank you for that. Yes.
That.
Okay, and just for closing, I wanted to ask each of you if you have a short future or remarks, closing remarks that you want to share with us. And we can go in order of presentation if that works better.
I mean, I think the message is clear. Exercise is medicine, and it's a fantastic complement to treatment trajectory.
Couldn't agree more. And I think it's important for us to figure out ways to spread the message and make it safe and make it available for everyone.
I agree, and continue to do what we're doing so we can hopefully add exercise to the standard of care.
I think it is a very exciting type of research, and I think that people need to know and be open-minded to improve cancer care with exercise, with the screening of sarcopenia, with the use of body composition as a way to improve care in patients with cancer and improve their quality of life.
Okay, and I think that's all of us for today. I want to really thank you all for sharing your tremendous work that you're doing both in the clinic and in research to improve patients' cancer care and outcomes. Thank you for taking the time to be here and answering questions and discussing with us all together. Okay, and now we'll just thank you again. I'm going to go ahead and share the last screen for today.
Yeah, thank you.
Thanks, everyone.
So much.
Thank you so much. Thank you.
Okay, so if you need to reach to any of the speakers, please use the contact information shown on the screen. I also would like to thank all of our attendees for listening and participating with questions. We hope this symposium was both informative and inspiring, and that you will consider joining us in future events like this. If you have any questions at all on the literature or InBody devices mentioned today, or have any general inquiries, we are ready to help you. You can contact us at clinical@inbody.com, whether it is to have a conversation with us about applications, or if you're interested in sharing your work with us and other researchers and clinicians. Also, please contact us if you need a certificate of attendance to apply for CPU credits or CPE credits if that applies to you. And please stay tuned for our upcoming InBody Presents webinars. More details will be shared through our LinkedIn page, InBody Clinical Research, and other media. We look forward to seeing you there in the next year. On behalf of all of us on the clinical team at InBody, I want to wish you all a great rest of the week, and as always, we encourage you to see what you're made of.